Start. Keep the recording going. Hello, everyone. Thank you for joining. We might still be joined by a few more people. Actually, Rasha just joined. But good morning. Hello. It's morning here. I keep wanting to say morning, but hello to everyone. Thank you for joining. So this is our 13th meeting of ISCET, and welcome to it. Today we're going to basically we're going to talk about what was covered last meeting and then continue from there. I don't think we have any specific new business unless anyone else has something that I'm not thinking of. But just to quickly go over what we talked about last time. So we discussed finalizing the subcommittee structure for the nystagmus standards that we're creating. So again, the plan is for this subcommittee to help write up and develop the actual standards that we're proposing for nystagmus, which was selected as the first area for us to develop standards in. We started forming that subcommittee, so if anyone is interested and hasn't yet said so, if you go onto our website, which is clinicalEyetracking.org, and go to the forum, there is a which standard to develop first post where where are we collecting that?
That is the one. It's not the best name for what it's now evolved into.
Uh, there is a which standard to develop first chain where you can add your name to the committee. Matt, I think the subcommittee hasn't started meeting yet, right? Because I haven't
No,
seen.
we were up until last week. We were waiting for the last people from ISEV to put their names forward. We now have those. So my action following this meeting, assuming nobody else wants to join that subcommittee, will be to actually organise that first meeting. We don't yet have a chair for that group. That won't be myself. It should be a clinician who's actively working and somebody who's involved in nystagmus. Nobody's yet put their name forward for that. So the proposal was that I will bring everyone together for that first meeting, and the first piece of business will be to identify who will chair that committee going forward.
Okay. Makes sense to me. Uh, okay, so if anyone here is interested and has not yet said so, please go on the forum, mention in your put your name forward in that post, and that way we know to reach out to you specifically for that. We also started thinking about the broader roadmap that we might follow for developing standards and guidelines and so on. And we've discussed again, this has come up a number of times. We're slowly trying to figure out what the actual formal membership structure for ISET will be moving forward, because eventually there are costs associated with running ISET, for example, running the website, and we will eventually need a formal structure in place for collecting any membership fees that exist, for making sure we are transparent in who the members are and how decisions are being made and that kind of thing, and making sure that we're following an appropriate ethical framework for how we're developing things moving forward. That is pretty much it, I think. I believe Matt was also talking a little bit about the practicalities involved in long-term adoption of eye trackers in clinical practice and just starting us thinking about those issues, right? You didn't have a particular ask there, Matt, right? That's just, we should keep that in mind.
No, it was just a few points raised about, who would be the likely groups that we would expect to be actually delivering it as a service, technicians or, is it going to be an orthoptist-led service in most places? Obviously, it will vary from place to place, but we was just thinking about the practicalities. One of the things which I raised in the last meeting was, and many of us who have worked in research of eye tracking might be familiar with this, that it's difficult to justify the introduction of an eye tracker into a clinic on the basis that the cost benefit is not really understood at the moment. And I would love to put together a piece of work where we actually work out what that is, in terms of chair time, in terms of the cost of setting the thing up and the training and so on. I was just thinking about kind of wider implications. It's all very well as coming up with standards and so on, but if there's still nobody joining the field, or we can't make the case that eye tracking is worth it, then there's little point in having them. So yeah.
Yeah. And the one other issue that came up, actually, I think after the last meeting, is that when we formed ISET, people who stepped into the organizing committee roles volunteered at the time, and we did not really have a election, as it were. It was entirely volunteer based because it was a new group we were just starting up. We uh, put forward names of people who were interested in doing it, and people stepped into the roles. But we want to make sure that, again, we're operating ethically and transparently, and that we're giving anyone the opportunities that they want, and also not pushing too much work on any individual person that doesn't want to be doing everything. So the current proposal that I haven't seen any objections to is that once this first standard is ready to be released, we should then proceed to open up, reconsider who's on the organizing committee, open up that for a general election. For any candidates that are self-nominated or nominated or however we want to proceed. I think the current question, uh, I believe that's the plan. I think the current question was more, is that the right timing to do it? And everyone seems to be in agreement from what I've heard, but I'd like to open that up to everyone here. So the question is really, do we need to do that right away? Should we wait until the standard is coming out, which means we're not like losing focus while trying to develop that first standard, um, or for some other specific time? Does anyone have any particular thoughts on that? You can just jump in.
Well, for me, I think it's just like a little bit step ahead because last time we agreed that we will do a formal but non-fees, yani membership, with no fees. I mean, we had Matt actually, hello everyone first, and then Matt did open a discussion, and but actually, I think I was also too busy. I should have taken this even forwards. But and all of us, of course, to discuss on he did a also a discussion tab on the website, but we didn't move since the last meeting on that. But we agreed to have of a formal membership that are currently unpaid. I think once we do this, then we can open the yes, I agree, of course, that we do, of course, elections. That's my opinion. I mean, but that's the sequence in my mind. Yeah.
That might be a reasonable approach because then we have a list of members who should vote, right? Um, any other thoughts? Agree, disagree? I guess, can I get a thumbs up from everyone that agrees? That way it's not just a blank abstain. Okay. We are trying to thank you all. We are trying to make decisions, as the way we've been operating so far is we're having these rotating regional meetings where any question that comes up, we're sort of going with consensus opinion into the meeting, pending that none of the other regional groups then later disagrees. So I do want to make sure that everyone is saying their piece, and so on. Okay, so we can put that forward into the forum post just to make sure there's no disagreement more broadly. So I can do that after the meeting. So we also, on that note, we have a forum post on, it's titled Looking Ahead to Formal Member Registration and Organizing Committee Elections. And that's where we're talking about this particular topic for committee elections. Generally speaking, when we're not in these meetings, we are still hoping to generally advance discussions through those forums. So I would encourage everyone to get on there. And then that is all of the business that I had on the agenda. So is there anything else we should talk about as a group? Because we have a lot of time to try to move something forward. But but that is everything that I know of to discuss at the moment. Matt.
Yes. Well, yeah. One thing would be then, of course. So, I mean, just for the benefit of anyone who thought this was the actual meeting where we're discussing the nystagmus standard, it's not. The decision was made in the last one that we would parcel that out to separate meetings. But then we'd allow other things to go forwards here as well. So one of the other things we talked about last time was how the other standards would fit into this. Obviously, when you have a nystagmus type standard, that's going to rest on a foundation of other types of standards, like, for example, basic processing via tracking data, blink detection, all that sort of thing. We will need to be mindful of how that will look, even if we haven't decided on the details yet. The reason we started with nystagmus, which is kind of quite a high level one, really, compared to that low level stuff, was it would give us a practice that how the process of writing these standards would work if there was disagreement among people about how those things should be defined. And we would assume that the underlying standards are of a sensible nature, but it would be an iterative process because it may well be that when we come to write the standard on other things like, for example, blink detection and so on, that we realize that requires a rewrite of the higher level ones. So one thing we will need to consider is at least coming up with a rough sketch of what the full set of standards is going to look like, even if we don't know what the detail of those is going to be. We don't yet have a kind of a library, a sense of how those would be and how they would interrelate. And the question really is, should we just dive straight into starting nystagmus on the basis that there'll be something sensible underneath it, or do we want to have an exercise of putting together at least an outline of what we expect those to be?
I know at one point, and I'm trying to remember which meeting this was in so I can try to find the notes. We had talked about potentially doing sort of a layered approach where we start with a generic algorithm for how to look at eye movements in a clinical setting, thinking through each step of that, and then having a disease-specific standard, and then also a additional set of standards for the type of test as opposed to the condition itself. I see a hand up. Go ahead.
Yeah, thank you. Sorry. I haven't managed to make it to many of these meetings, so apologies if this is dim, but I'm talking about the nystagmus standard here. So I'm Jay. I'm a clinician primarily. I do have a background in nystagmus research and done tracking, etc. But I run a big nystagmus clinic. These guidelines that we're talking about for nystagmus, I think what I'm quite mindful to make sure we start early is trying to get evidence for the standards that we're coming up with. There's a difference between thinking about the best ways to do things and deciding whether those things are actually clinically useful or not. And I think we need to make sure we don't get those things on their head. So what I mean by that is we need to work back from what is clinically useful to know in certain groups of patients. And I appreciate your point about standards for different disease conditions, etc. But nystagmus is such a broad kettle, and we're talking about different ages, we're talking about very different clinical scenarios, and in our experience, I know it's just one set of experience, but what we need to know in an individual patient, which will actually change what I do, is very specific per patient. So I worry slightly about standards. I mean, you can obviously have standards for lots of different things and just select the thing that you want to know at that time. But I just want to make sure that we're mindful that having a whole battery of tests for every patient is never going to work. It will not work for various reasons. So yeah, sorry if I'm not trying to sound negative. I'm trying to chip in with the very clinical angle because that's what we're talking about here, trying to get this into clinics, right?
Yeah. Matt, go ahead.
So Jay and I have actually corresponded about this already, and I completely agree that in any of these standards, the first thing that it probably should set out is the circumstances in which eye tracking is necessary and appropriate. And of course, they will have there'll be variations in terms of what you can actually achieve with different patient groups. So I completely agree with you that we need to make sure that anything that we're collecting is actually going to make a difference to management. Otherwise, there's no point in collecting it.
Yeah.
So yeah.
Yeah, thank you. And maybe it's worth mentioning that we talked a little bit, Matt, about trying to look at some data on a whole cohort of patients. We have lots of other people have cohorts of patients, but me and Matt have sort of talked about this very briefly about what we could actually do, because the vast majority of our patients don't actually have eye tracking. We can work back and say, should they have had eye tracking at this point, this point, this point, this point, and the eye tracking had been perfect and told us the thing that we were looking for, just so we exclude all the sort of methods stuff from it, how would that have changed practice for that patient? Because I think that piece of work hasn't even been done. So I just can't quite get my head around writing clinical standards without knowing that stuff, you know?
Yeah, I think that
I
would
don't
be a
know what
really
other people think. I don't know what other people think.
that'll be a really useful exercise. And obviously, if you've got that data set already, you know what the patient's had, and in some cases, you have eye tracking, perhaps for a research point of view. Then you could say, had we been able to use this clinically, then we would have, that's a really useful resource to have, and it might set a precedent going forwards for how we can actually address this with other clinical disorders beyond nystagmus. And that feeds back into that question that I was asking about of how do we prove the effectiveness and usefulness of eye tracking? Because a lot of the time these eye trackers are not CE marked, or they're not marked for clinical use, and so people can't use them clinically. But we have, in cases like yours where you're a clinic but you also sometimes do the research, you've got the ability to do those things on the side and prove potential usefulness. So yeah.
Yeah, and we've got other clinicians on the call, so it'd be interesting to see what they think about it. Oh, Denise, go hand up.
Yeah. Well,
You
what's the-
said that,
there
you
you go.
said that it sounded like with a bit of a groan. But no, I was just
Not at all, sorry. Not at all.
confused about what we mean by standards, because I think we've previously spoken about the difference between sort of methodological standards and testing standards. I think what we're talking about here is sort of almost like clinical practice guidelines, when to use eye tracking for particular clinical scenarios rather than standards, or how I interpret that word, the meaning of that word. And maybe also what might be useful is how to interpret the results that you get from eye tracking. What information to extract from that data would be useful to a clinician.
I know we've also talked about at some point making sure that whatever is produced is flexible enough to allow people to do what is necessary. So if the concern is that we're going to step forward and say, you have to use this value, period, I don't think that was the current plan. Yeah.
No, I mean, I think also we kind of we're following the model set by ISCET with electrophysiology, and there are particular standards for the actual testing environment and how to measure electrophysiology. But you would never say that every single patient has to have this complete battery of electrophysiology tests to assess their vision. I mean, everybody knows that you sort of select out or recommend the tests that you think are most appropriate for the clinical scenario.
Yeah, I do think in nystagmus, though, we were starting from a very wide church. Just having been to the ANN in Philadelphia fairly recently, there are people there who think that every patient, full stop, should have eye tracking, and without it, you cannot consider yourself a clinician. And then there's people right at the other end who say, I haven't even got an eye tracker and I do just fine, thank you very much. So we're starting from a very, very broad church. But I do think it's a very important one. So I'm not suggesting you don't do nystagmus first, but I'm just forewarning you. I think we probably need to really pin that usefulness of that bit of information in that moment before we even look at the best way of doing it.
Yeah.
I just feel give you just a bit of context on some of the things we discussed before. So with regards to guidelines versus standards, the terms we've pretty much used interchangeably, but I think following ISEV's model, the last thing that was agreed at least was that they would be called guidelines in the first instance, and then the word standard would come with like iteration 2, for example. That's how they've done it, but that's not to suggest that they are enforced in any way. There's no such thing as that. It is only ever really guidelines. And secondly, just to pick up on what these things would encompass, there's a huge amount of things that the ISET has said it would like to encompass, like for example data formats, an open data format for eye tracking that's interchangeable between different eye trackers. That's a very sort of low level technical thing, but it probably would be a worthwhile thing to do, so people aren't forced into using a particular brand of eye tracker. Then you've got things like the protocols themselves. So when you're collecting the data, do you have saccade steps of 5 degrees, 10 degrees, whatever? That's another form of standard. And then finally, what you were saying about Denise, the processing of that data, that's when it comes down to things like blink detection and velocity calculation and all those things. So those are slightly more technical aspects, but they do still feed up to the clinical, if you're going to make a diagnosis, you want to make sure everyone's doing it in the same way. So that was just to give some context to what we said before.
I know I saw a hand up and then it went down before I saw who.
Hi. Yes, my name is Fatima Shorkat. I work in electrodiagnostics in Southampton with Jay and Helena. So I do mostly visual electrodiagnostics, adults and children. And in ISEF standards, you're probably all aware that when we see children, we have to adapt the tests, and the standards are not so stringent, as I'm sure a lot of you are aware. So I'd imagine for eye movements, we'd be doing the same thing. So we do sometimes when we do nystagmus clinic with Jay, and it's valuable to look at the nystagmus waveform, we will just stick some EOG electrodes on and just look at the waveform. We're not particularly worried about getting everything done. We don't even calibrate, because quite often when you have a 4-month-old baby, it's really difficult to calibrate when you haven't got fancy eye movement recording systems. I would also look at OKM and Pursuit, and just try and get as much information as possible. So I'd imagine if we do a pediatric sub section for the standards, then it would be like the ISEF ones, which are far more flexible to allow to get as much information as possible. That's going to help the clinician. That's all I want to say, really.
That seems likely to me. Yeah.
Sorry, I can't find my the hand up button, but
Oh, you're
just
good.
mention a few things. Yeah, so I'm Omar, and I was part of the last meeting as well, and I'm kind of involved because I'm director of standards at ISEV, and I'm a bit green in that role anyway, but without any particular expertise in nystagmus or anything like that. And as you were saying, ISEF has a standard, and it's a little bit more evolved in the journey of setting standards and having a formal membership that votes on it. But also, there is the flexibility there to there's an abbreviated protocol for use in children where you don't go through the full ISEF standard. So I'm a big fan of not being too prescriptive. Maybe not the right person to be director of standards at ISEF, but yeah, I'm a big fan of flexibility and not making, and especially in something that there isn't a big evidence base for to start with. Maybe a guideline is right to start with. Ruth Hamilton, president of ISEF, was hoping to join, but I think she wasn't able to. But she's in the process of writing a document about how ISEF sets its standards, which can presumably be shared and take from that what you will. But I think, as Jay said, making sure you specify what's clinically useful rather than being very prescriptive and saying it has to have every test, and probably starting off with a guideline rather than the standard would be a good idea. And what I've also noticed is it's because these things are international, it's very different, our practice in the UK from elsewhere. So we're happy with certain standards and then changing it. But in say the US, where it depends whether the insurers are going to reimburse tests. It really makes, and this was why there were quite active discussions at ISEV about whether something could be called a standard or not, and it was really driven by what was likely to be insured in the US. So these things have to be taken into account as well. But generally speaking, not being too prescriptive and having a guideline, I think would be a good start.
Given the amount of thinking that ISEV has done already on how these things should be developed, having that document would be fantastic, actually. Yes. I'm sure that would be helpful. Jay.
Yeah, that's really interesting. Do you think there's a world in which we have almost like a hit list, a little bit like we do clinically with when you have a 4-year-old and you want a nice Heidelberg OCT scan of their retina? We have a Heidelberg perfect, Topcon not too bad, handheld, worst least bad scenario. Could you almost have that per thing you're trying to ascertain? Do you know what I mean? So almost a gold standard and then a couple of levels below it, because I think in reality that's what's going to make people do stuff if they see one that's actually achievable. Is that how it could work?
I don't know. I don't see why not.
So for example, checking saccade velocity, whatever, you have your perfect scenario, then you have one that if that's not perfect, the next best option is this, and then all the way down to waving your hands in front of them and filming on your iPhone or whatever.
Yeah, I think I'm not on the subcommittee that's deciding this, so someone else would have to speak to that. But I don't see what a reason that we wouldn't be able to do that. Denise?
I sort of feel like we should do what everyone else does and start with adults because it's more straightforward, and then sort of adapt it to children. And also those children that have nystagmus are going to grow up to be adults with nystagmus. So many of the same things are going to still apply.
Yeah.
I suppose, sorry, I was just going to say, those children are going to grow up to be adults where you can do these fancy tests on. Sorry about the dog. But obviously, when you have your 4-month-old coming in with nystagmus, you need to answer the questions that the clinician wants. Is this neurological nystagmus? Is this INS type of nystagmus? So you're,
I totally agree. But in terms of writing some clinical practice guidelines or standards or whatever we want to do, it's always easier to write them for adults first and then adapt them for children, even though they may be more useful in the pediatric population.
Matt?
Yeah, I agree with that approach. You have to start somewhere. I mean, obviously the standard is going to include both, but I agree that at least you can start with the ideal scenario, and then, as Jay was saying, you work your way down from there and say this is at least the minimum. None of this is as we say, prescriptive, and also it's worth bearing in mind that one of the major reasons for doing this is to enable new clinicians to enter the field. Eye tracking is daunting for a lot of people, and having the only way whether I should, what kind of low pass filter I should use in my data is to refer to the literature at the moment. So having a set of guidance, almost like training notes, would be really, really helpful for that reason. So if we try and think of it more as not being a prescriptive set of telling everyone how they should do their jobs if they're already doing it very well, and instead being about providing guidance to new clinicians. And obviously, there is the benefit of allowing patients to be able to move between different clinics when everyone gets on board with these standards, but it's going to take many years to get there. We've got a lot of even just to begin using the nystagmus standard, you have to have all these other underlying ones before we move on to the next disorder. So there's going to be, this is going to be an ongoing process for a very long time.
Andreas?
Yeah, in that line, it was quite interesting when this subcommittee started. It was only titled nystagmus subcommittee, and meanwhile, infantile nystagmus subcommittee is labeled, and there are lots of adults that have this nystagmus due to cerebellar or other diseases, and the eye tracking is the only way to protocol really an effect of a drug, let's say for miraculous deeds or something like that, and which is helpful for announcing it to the insurance companies to pay for the treatment with the drugs. And therefore, I think starting from the adults with the normal healthy adults, the older one, and then going out also to the younger ones.
I think we can pass on this suggestion to the whole subcommittee. Matt, you have your hand up.
Yeah, I just wanted to clarify. Yes, originally the standard was going to be on nystagmus as a whole, which includes all kinds of vestibular nystagmus, gaze avert nystagmus, and so on. And it was the Asia Australasia group that decided. Obviously, we can change that decision, or at least have a think about it. To focus in on infantile nystagmus. So I should also clarify that infantile nystagmus does not mean that the patients are children. Infantile nystagmus begins in infancy and continues through adulthood. So it was really just a way of providing a focus to that initial standard production, because otherwise we could be, we want to try and create one thing to start with, and so that was the decision that the Asia Australasia group chose. But that's not to say that other forms of nystagmus in adults are not important, and certainly they are.
But again, nystagmus as a whole is quite broad, right?
Yeah.
So narrowing down to any degree will be helpful in getting the ball rolling. And again, part of the goal here is just to establish one thing, so that we've now established our process for setting up these guidelines or standards, so that we can then continue to do it on a larger scale and start to cover all the different angles that we all care about. Yeah.
Sorry to keep saying. Just you're right. We would do one initially, and then that provides the process of learning how it would happen. So we wanted to do that slowly rather than trying to do everything all at once. Which, if we find that our processes aren't quite as they should be, then that would be difficult to reconcile.
Helena.
Hi, I'm one of the other clinicians in Southampton, so we're a little Southampton dominant today. But I just feel a bit worried about focusing on just infantile nystagmus, because one of the best uses of the tracker is to figure out those cases that aren't actually infantile nystagmus. So you might already be decreasing the potential utility of the tracker. Do you see what I mean? Because we mostly apply it in say, for example, young infants, where we're not sure if it is infantile, one of the ones where we're not worried it needs an MRI scan, or something that's acquired.
That's an interesting point.
One of the big uses of it is differentiating between the nystagmus that we worry about versus the safer types, shall we say, clinically.
I kind of imagined that this was going to include aspects where, you're looking at this in order to differentiate it from other conditions. I don't know if that's how anyone else was thinking about it, and I was not explicit about that, so I don't know.
I think we have a nomenclature issue here. We're not. I don't think we've been talking about INS. I think we've just been talking about infants with nystagmus, because we don't even know they've got INS yet. That was my interpretation. We're talking about the utility of the tracker in little ones who've got nystagmus, and we're trying to work out what's going on, not INS. Because once we get to that point, we're halfway there.
Okay.
So because I thought there was going to be a focus on adults earlier on. Do you see what I mean? We haven't really nailed down what we're doing, because we're doing adults. Adults could be acquired, or they could be grown-up adults with infantile nystagmus.
But it has to be based on presentation, otherwise it's a pointless guideline anyway, right?
Yeah.
So adults has to be adults, surely, including the acquired, including the ones who've slipped through the net and are actually INS, etc., etc. I would imagine.
I think that's so in the Asia Australia meeting, it was decided to focus on infantile nystagmus, but I think you're absolutely right that somebody doesn't present with infantile nystagmus, they present with nystagmus.
Yes.
So we may need to rethink that decision that was made by that group, because you're right, that doesn't, So in which case we come back to the definition of it being the standard for nystagmus as a whole, not just infantile nystagmus, because perhaps it's impractical to just, and that could apply to adults or children. If somebody turns nystagmus, of course, it's unlikely that they'll suddenly present with infantile nystagmus as an adult, but
I think you have to base it on age, because that's how people present. You present as an adult with nystagmus that you need to try and work out what's going on, or a child, or something in between. You don't really present with anything more detailed than that, and if you do, then we're going to have a million different guidelines for the ones who've come from neurosurgery wards or whatever, which is pointless.
Could you narrow it down a bit and focus on either asymptomatic presentations, which are more likely to be early onset infantile, or symptomatic presentations, which are more likely to be acquired? And
I would imagine that needs to be part of it, doesn't it? Part of it, that's going to be one of the strings of the diagram, I would think, because there's so many other valid potential splits, isn't there? I would say
you're looking at the same potential things, whether the symptoms or not. Yes, it's more likely to be acquired with oscillopsia, but to write a separate standard for each. I think, as Jay said, it's a nomenclature thing. We've got this, we want to try and create these nice, tidy standards, but in reality, the presentation.
I suppose I'm thinking more clinical practice guidelines, because really what we want to define is where eye tracking actually helps change your management or direct you to a different set of investigations that you wouldn't have done otherwise, maybe, or you would have done the whole gamut of investigations instead of narrowing in on a particular set based on your eye tracking results. And maybe either one of those groups we could pick those, because I think eye tracking does have a place in potentially guiding you to a particular set of investigations. Otherwise, what's the point really in doing eye tracking, other than monitoring, I suppose, response to treatment?
Would the idea here be to focus on a suspected aspect where you're trying to differentiate whether this is it or not? just clarifying from my side, I'm not a clinician, so my focus is not nystagmus.
A common presentation, if in the UK we get a lot of referrals from optometrists working in the community, and they might refer a patient who's completely asymptomatic, but they've noticed they've got some kind of nystagmus. Usually that's a very early onset nystagmus, which is developmental in origin of some type, and you're not too worried about it, but people do get worried about it.
Yeah. So for me, that's quite. You definitely could do that. I just worry that that's slightly too specific, because essentially you're going to say, look for accelerating waveforms. Few, no symptoms, you're fine. Do you know what I mean? It might be quite short, more short one, I don't know. But I'm just wondering whether we need to be a bit broader than that, although there's a million nuances. We know that. That's what this whole thing is about, right? But I worry slightly about that as a very specific scenario, because then there's the ones that present who've, had a bit of oscillopsia, but not much. They've had some oscillopsia, they've had loads of oscillopsia. If you really grill them when they're drunk, they've noticed it for years. Do you know what I mean? There's so many grey areas in there, I would say. If we start trying to
I was thinking of that group mainly because it would also apply to the pediatric population.
Matt, you had
it is one of the key questions, differentiating between the neurological acquired versus one of the congenital forms.
Yeah. But just having a whole guideline about that specific scenario, though, I mean, we're trying to make this broad for people, aren't we? I worry slightly.
That's the broad question, and then you go into more detail about other aspects that you might need after that.
Yeah.
Like, is there pan if I'm going to operate? Is there, 2 null points because it's very confusing? Is there?
Yeah.
Yeah. That kind
of thing. Another thing we could go on the back. Earlier I said you can use eye tracking for monitoring. So eye tracking has been used in clinical trials for MS drugs, for example. That's one of the large uses in research, actually. So we could produce some guidelines about what eye tracking parameters are actually useful for monitoring purposes in clinical trials. That is quite specific again, but quite useful.
Matt, you had your...
So I had a proposal. I think Helena's pretty much said the same thing, which was that I think we should basically, the proposal is that we should do differential diagnosis of nystagmus as the first standard. Now, whether that then, as we're developing it, evolves into slightly more or less, I don't know. But if we just had the whole of nystagmus, there is 1,000 different routes it could go. How do you characterize null zones prior to surgery and so on? If it was just to focus initially on differential diagnosis of nystagmus, you can do that both in adults and children. You can do that symptomatic, asymptomatic, but it is a narrow, single focus question. And if we at least, convene the group initially to try to answer how do you approach that question, that they may lead to other projects, other standards. These standards are going to be layered anyway. So this could be like the master one for nystagmus, and then you'll have substandards within nystagmus. That's my proposal anyway. So we focus on differential diagnosis of nystagmus.
Omar?
I found the hand raising thing. Just to say, I mean, the ISCET way, which totally doesn't have to be the right way or the way you need to follow, but is usually just to specify, have a standard for each type of test, rather than this is what you do in a patient presenting with this, or this is what you do for this diagnosis. It's more, these are the parameters, because the world before was every lab doing some completely different protocol with different flash intensities, and no one really being able to speak the same language. So, it was decided for full field ERGs, you want to assess the rod system, the cone system, this is how long you dark adapt for, this is how long you light adapt for, these are the parameters for recording, these are the filter settings, because it could completely change your waveform. So that was immensely helpful for people, whether it made things too solidified and hampered things, I don't know, but it was immensely helpful, because then every clinical lab does the same thing, and suddenly people are speaking the same language, rather than patient presents with this, do this and this test, more like this is what the test should involve, and this is what you could get from them. and then maybe and then this could be how you differentiate these things. There may not be the right way to do it, but also might be an easier way to do it, and also depending on where the field is now, as you were saying, for people coming into the field wanting to set up an eye tracking service or something. Well, what would I need? That's I guess the way ISEV have gone about their standards. Rather than taking a disease, they've taken types of tests and suggested what the best parameters are. But obviously, it doesn't need to be done that way.
I think a concern was raised at one point that certain tests would be used in different scenarios with very different filter settings and that kind of thing. I don't recall the specifics there. Matt, I saw your hand.
I was just going to give a bit of history on what we discussed prior to this, and it was with Ruth on board, obviously the president of ISEV, that ISEV has, it makes sense to do it based on the different technologies that you use, EOG and VEP and so on. Whereas, yeah, for this, because we're looking at conditions like anti-saccade testing in schizophrenia, or some of these things, might be about where you look. For example, there's uses of eye trackers in autism. The parameters of the device that you require to do, where someone's looking, you're doing that with a webcam. You can't do saccade dynamics with a webcam. So that's why we felt that we would need to lean more towards the diseases. But having said that, we then came full circle a couple of meetings ago and said, well, actually, there will be some things which are common across the devices. So there's going to be this weird hybrid between standards for the diseases and standards for the eye trackers. And we still haven't come up with a very tidy way of reconciling that. I don't think there ever will be necessarily. I think some of this will just work its way out as we begin to write something, put something to paper.
I think the closest, the tidiest suggestion I've seen so far was the idea that we could follow an algorithm from start to finish and say, like, here is the particular test, the particular settings, the particular way you're looking at everything, how you collect it all, and then what the decision might be at the end of that, because then that sort of flows through the whole process. But I agree that there's a lot of uncertainty here about the right ways to go about these different issues, and how to get at things. Fatima, did you have something to?
Yeah, just following on from what Omar and Matt were saying. So in ISEV, you have your standards, but then you have your basic tests that you will follow in an adult, shall we say, and then you can always add on layers to investigate a test a bit further, like looking at enhanced S-curves or whatever. And when I worked with Chris Harris at Great Ormond Street, we also had a basic eye movement protocol we followed. So we would, apart from looking at the nystagmus and the waveforms, we do the different oculomotor systems. We'd look at saccades, pursuit, and then we'd look at the OKN, monocularly, binocularly, we look at VOR suppression. So this is one way, I suppose, you could define an ideal steps that you could follow in the compliant patient. And obviously, if you had an uncompliant baby, you would just get as much as you can out of them. But we actually followed particular steps to look at the different oculomotor systems. This is something you can definitely do with adults, obviously, and that would answer Denise's comments about what we should follow as a basic standard. And then you can always add on the anti-saccades for your schizophrenia or whatever. You can always add the extra bits like we do with electrodiagnostics.
So the focus would be the steps of the test, basically.
Well, no, it's just you're trying to find out where the pathology is, shall we say.
Right.
Let's say a 6-year-old comes with nystagmus, you look at the different systems and see how that fits in. So if they have, see whether it's the nystagmus, whether it's latent or whether it's an INS type of nystagmus, you can look at their OKN, which should be disrupted in an INS type patient, or you look at OKN asymmetries. So is it a nasotemporal asymmetry? Is it a bilateral asymmetry? Is it a brain problem, or is it actually an amblyopia type issue? So we went through all the systems, and I wish Chris Harris was here actually to explain all this better, but we went through all the oculomotor systems, and then we wrote our report, and with the sort of hints of what these eye movements by me might lead to from a clinical point of view. And obviously we did this in children. This was at Great Ormond Street, but we couldn't always get everything on them. But we got enough information to be able to help the clinician or the neurologist or whatever. Obviously, this is much easier to do with adults.
Matt?
I really like that suggestion, Fatima, because we have, it short circuits the issue of whether we focus on the technology or on the disease. You won't focus on the systems that are being tested. I think for a lot of cases that would work. It might not work in nystagmus because, nystagmus is a separate thing. Again, you're not really, where you could be saying you're testing fixation, but then you wouldn't be looking for accelerating waveforms in normal fixation, perhaps. Or maybe you can. Maybe you could just do it that way.
Well, in nystagmus patients, looking at the OKN itself would be really important because that can help in lots in the diagnosis. So, if it's a neurological type of nystagmus, then the OKN is normally preserved. If it's an INS type of nystagmus, then it's disrupted. And also, you look at the latent, you can see how it changes monocularly. We used to have an infrared camera, so you could see what the nystagmus is doing in the dark as well. So I think it's helpful across all sort of cases.
Jay?
Yeah, thanks. Yeah, just listening to Omar, I think I've changed my mind. I think Omar's changed my mind. I wonder whether we should be leaning a little bit further away from clinical guidance, thinking about it, just because there's a few things about mandate, reach, remit, etc. To be completely honest, when we start saying people should do this for this clinical scenario, I still think we need something in there to say why this is useful, because otherwise, frankly, no one's ever going to do it. It's going to be a big old waste of time. But if we focus more on, as we say, systems, so if you want to know about the OKR in a patient, this is how we think you should do it best, with a hit list of order of best to worst. Same with saccades, same with smooth pursuit, same with VOR, whatever. And then the next step, after we've pinned those, then we can start actually looking at, because I don't think there's the evidence yet, looking at and reporting on why it's useful to know about the saccades in these particular patients. That would be phase 2. So maybe that's where pinning it down. I think that makes most sense to me, having thought about it and discussed it.
So should this first standard actually be on fixation rather than infantile nystagmus?
Maybe it should be on. I mean, fundamentally methods. I mean, that's what ISEF is. As you say, ISEF doesn't tell you when you should do it. You should do, whatever you're going to do. EOG. It's not going to have really strong opinions about when EOG is useful, but it'll tell you if you're going to do an EOG, this is how you do it, I guess. I think maybe we go down that line, because I think there'll be some nuance in there which will help with the follow-on stuff. Yeah, Omar's very much changed my opinion. I think that's a really good thought.
The better. Hope I didn't make it worse.
I like that a lot too. It seems like a very practical approach, right? Which is kind of the goal, is so that people can pick it up and run with it. I didn't have anything to add other than that. I also agree that I kind of was sorry. Go ahead, Matt.
We'll go forwards with, we've got a lot of people who have expertise in nystagmus are willing to start making this first standard. If it's not going to be on nystagmus per se, as I was suggesting, it could be on testing of fixation stability, which inherently involves, that is looking for nystagmus, but it's by a different name. And so that would be one system, the fixation system, testing of the fixation system, unless people have another suggestion as to how we can use the subcommittee we've already recruited in a way that's beneficial for nystagmus.
Well, we can use that committee to work out which of the systems are useful in people with nystagmus. I mean, that'd be step 1, right? I mean, looking at anti-saccades, where hopefully we're not going to say is a good idea or useful, right? So that would be the first job of the nystagmus specific committee, and then perhaps that could then feed into, okay, we know what systems we want to look at in nystagmus and probably, frankly, most other conditions, and then start working on the actual methods for them, maybe.
Mm-hmm.
Then you haven't lost your nystagmus gang.
So do we want to specifically ask the nystagmus subcommittee to reevaluate and determine whether I mean, they haven't met yet, right? So they haven't settled in on exactly what they're doing. It, I think, is reasonable to say, like, at this first meeting, discuss the approach and confirm whether or not the path they're going down makes sense, right? whether there's a better option. And we can suggest this approach to the subcommittee.
Yeah.
Yeah.
Yeah, I think it's specifically what that the committee can come up with what is useful to know from eye tracking in patients with nystagmus.
Yeah.
That's basically it, isn't it? And then you can think about how and why and where, because I think you will have a variety of opinion, to be honest, even on that.
Fatima?
My other concern is are you going to be determining recording techniques or apparatus? Because that can be quite problematic in children. And what were your thoughts on that? Were you thinking of everything's got to be done in one particular way, or you know, you're gonna have a few suggestions?
No, we don't want to limit specific technologies. At least that from previous discussions we had said we would indicate okay, for some particular tests you really need particular hardware needs, right? Like you as Matt pointed out before, you can't really measure saccadic movements with a webcam, for example. But beyond that, I don't think we're specifying like I know we don't want to say you need this particular brand of eye tracker, right? We don't want to go that route. And I think the idea is to leave the hardware side a little more open, but to say what the specific needs are kind of in a, you know, if you're going to do this particular test to find out this particular answer, these are the at least minimum specifications and settings and that kind of thing that you would need. That was my understanding.
Yeah, that definitely makes most sense to me. So if you literally can't see that thing at lower than 500 hertz, that's the general principle, right? But yeah, be agnostic as you can, not least because frankly, you don't want to have to redo these guidelines 6 months later when someone develops some new kit, right?
Yeah.
My worry is a lot of the kit is not suitable for babies and children, or getting them, you know, like looking at gaze-threatening nystagmus, getting them looking eccentrically, or so, you know, I personally like EOG, basic old EOG. But I'm just wondering, are there people going to then comment saying, "Oh, that's not actually good enough because it's not going to pick up subtle eye movements"?
If you're using EOG on babies and you believe it to be good enough, then it's good enough. You know, that would be fine. It must be because you're doing it, right? So if we would be defining like minimum standards in terms of frequency of recording and precision of the actual signal that you get, but that would be based on what's pragmatic for actually being a minimum for diagnosing whatever it is that you're trying to diagnose, or perhaps as when I'm pivoting to the systems, what would be required to properly analyze that system, not to a super high level, but just to a minimum level. So EOG must be suitable.
So I think I mentioned last time, I wrote it down, we are working with the SPN people who provide our electrophysiology systems. And a lot of places use the SPN system. We are trying to work with them, but they haven't got that much time for us to do this, is to try and get them to develop stimuli that we can use using the EOG, and then we can record it while recording the ERG and the VEPs, which is just be amazing because most people will have electrodiagnostic equipment, but they're not necessarily going to have eye movement equipment. So by using the EOG with the SPN system, we can look at hopefully OKN and saccades and look at the nystagmus waveform. That's what I'm doing in Southampton at the moment. Not very often, but that's what we do when we have to.
So I think we're coming up on the hour mark soon. So the question is what we want to do to hand this off to the nystagmus subcommittee and say we think that you need to discuss whether the original plan is the right way to go, whether we should take a more systems-based approach, or can the committee during its first meeting figure out the detail, a direction basically, with our suggestion being that coming up with what is useful from eye movements in terms of which systems and general assessments are useful for patients with nystagmus. Does that sound like a reasonable handoff?
Yeah,
That sounds pretty reasonable as one of the members of that committee.
Okay.
yeah, and I think Matt, will you be calling for like a subcommittee in a Stagmus meeting soon?
Yes, because
we-
Ruth sent the list of people who were joining us from ISEV in the last week. So yes, I'm going to be calling that meeting soon. And I guess I'll put in for about a month from now, and maybe give a poll for people to when's going to be the best time for everyone. We do have the issue that we don't have the same luxury of being able to do the 3 rotating time zones as we have for the main meetings, so that's likely to cause some problems. We'll just have to go with the majority of people that are able to attend. But it sounds like if we're only having that group define the systems that need to be tested, then it could be quite a brief meeting. If we don't then go forwards and say, all right, let's look into the system of fixation stability or whatever it might be that's decided, it could be quite a brief one. So it may not even require an actual meeting as such. It could be done by email. Probably.
I still believe that we would like present this as suggestions and recommendations because, for example, the Asia Australia meeting said infantile nystagmus. This meeting had further discussion, and then honestly, it's up to the people in the subcommittee and also their expertise and their and what would benefit the guidelines. We agreed this is guidelines more than standards to start with. So I believe it's the call of the subcommittee also to make the use of those people there. And it's always like, I think better to avoid confusion to frame this as suggestions, not like that we all agreed to do so and so.
Right.
And I think that when we did the subcommittee for the survey that actually led to this work with Gemma, and it was also people from different zones, I think it was quite good. Everyone did contribute. We had a document that everyone was involved in. So I think we already have a pretty good experience in that. So I'm really optimistic.
Sounds good to me.
I'll write to the subcommittee immediately after this meeting then and try and find a suitable time for them all to meet.
Okay. Does anyone else have any business we should talk about? No? All right, well, then thank you everyone for joining. And please watch for messages. Again, checking the forum would be helpful. And we do also have the general email list so you'll see announcements for the next meeting and that kind of thing. Thank you, everyone.
Thanks, Robert.
Thanks very much.
Bye.
All right.